So welcome back to the podcast, everybody. My name is James Waldron, GP and GPnotebook podcaster and educator. And this is our final episode in the 4-part series of HIV in primary care. Over the last 3 episodes, we've covered testing, diagnosis and prevention, PEP and PrEP, and we've been on a real journey. And today we're talking about something that underpins them all, stigma. As mentioned, this is part 4, so there are 3 other episodes waiting for you to go back and listen to them. So if you had the chance, go back. There is lots of learning to be had. But to today, what is stigma? Where does it come from? And crucially, how can we challenge it in our day-to-day work as GPs? Joining me is our series regular, Dr Grace Bottoni, but our special guest today, Darren Knight, Chief Executive of George House Trust, an organisation working at the heart of HIV support and advocacy. It's a thoughtful, honest conversation and one that highlights just how powerful our words and actions can be. So welcome Grace and welcome Darren.
Hi James, thanks again for having me.
Hi James, thanks for having me too.
Brilliant. Well, we covered so much in this series. It's been really interesting look right from the beginning of diagnosing HIV to trying to ensure that we're screening, getting treatment started, as well as PEP and PrEP. And we've been through a right journey surrounding this super important topic. But now we're moving on to something slightly different. And we're going to be looking at the language that we use and challenging some of the assumptions, beliefs, and thought processes that we as GPs have, as well as the public. And we're looking at stigma today. Really interesting topic. Darren, can you tell us a little bit more about the George House Trust and yourself?
Yeah, so I'm the Chief Executive of George House Trust. We're a charity supporting people to live well with HIV. We're based in Manchester. We work across Greater Manchester and Liverpool, but I like to say that we're kind of locally focused, nationally relevant, because a lot of our work kind of works with a range of different partners. We do research and engagement, but also we're providing one-to-one advice and support to people living with HIV. And as this is a GP podcast, I think the easiest way to describe it is we're kind of the social prescribing hub for HIV, really. So you're referring to us, and if we don't do it, we'll find the people that can. But we do everything from providing formula milk to new mums and babies, to providing counselling support, peer support in clinics, and loads of social activities and things like that as well.
Well, that sounds absolutely wonderful, and I'm glad that it's sort of nationally focused. So it's really great to know that advice is available, and it also goes to show just the breadth of support and considerations we need to be making with our patients living with HIVs and their family, of course.
Absolutely.
And that really links into stigma. So I suppose I'll come to you, Darren. Why are we talking about stigma?
Well, we're talking about stigma because we've seen massive progress in the HIV response, or the medications that people can get. Kind of people will live a long, normal, happy life when diagnosed early and on effective treatment. But we've been really slow at keeping up education, changing attitudes in comparison. And people's understanding of HIV is really rooted in 80s and 90s, the 1980s and 1990s, not in what it is now. And so we need everybody to catch up. And we know through surveys and research such as Positive Voices that a lot of that stigma is experienced in healthcare. And so we need to really work to educating the entire workforce as well.
That sounds like a wonderful mission. And it sounds like an unusual thing that we would need to be educated in healthcare about stigma. Surely we've got this on lock. Tell us about some of the challenges we face, Grace, in primary care and with HIV.
As Darren was saying, there's still a lot of work to be done, specifically with regards to HIV stigma. So negative attitudes and beliefs that are perpetuated about people living with HIV, and it is a historical thing. But that is sadly what is currently driving transmissions of HIV, and also a lot of people living with HIV are not accessing treatment or not going to their clinics because of stigma. And yes, there is a lot of stigma within our society, but there is also still stigma amongst our healthcare teams and healthcare professionals. And that is what we are here to sort of raise awareness about, but also provide some solutions.
Yeah, I think it's great to be able to challenge this, and I think even by listening to this podcast, people are going to hopefully start to challenge their beliefs, challenge their thought processes around this really important topic. Um, I suppose we talked about stigma in general there. Why is HIV stigma different? Why is that a specific thing we would need to consider?
Um, I think that when we're looking at HIV, we've got to think about the attitudes, the understanding, the history, really, of HIV, the origins of the virus. The kind of, if I think back to the early 80s, all the sensationalism, all the headlines, gay men, sex, drug users, sex workers. And so that prejudice, that judgment, that kind of homophobia, the racism, considering Black African communities, all that is kind of put together. And actually, ultimately, if HIV stigma feels different on the basis of you've got all that stuff going on. And so it's those deep held attitudes and judgments that people have, prejudice, that kind of hasn't been challenged in the way that it needed to be, and that we haven't re-educated to say that actually HIV can affect anybody, absolutely anybody, and we need to kind of make sure that everybody knows that, really. And so we've just got a bit of catching up to do, as I mentioned earlier.
So I think we also have to consider where stigma also comes from, which is misinformation and lack of education, particularly when we think about healthcare professionals, but also people that work in a GP surgery, so also nurses, admin staff. So people might, or people still might not know that you can't pass on HIV if you're on treatment and you're undetectable. And we also hear stories of admin staff collecting urine samples with wearing gloves if that person is living with HIV, even though it's in a plastic bag already, but they fear that they might, get HIV from touching the plastic bag and so on. So, and that is lack of information, really, and fear, and um, that to me is so frustrating because I feel it's quite an easy thing to do for us, do educate people. But I guess if you don't know what you don't know, right? And there is still a lot of other stigma surrounding HIV. So that is really, it's something that we could easily do in general practice to educate our staff on HIV.
I mean, and stigma, kind of runs deep. I was thinking we've mentioned the words "you equals you" a few times over the course of these podcasts, and understanding or knowing that undetectable is untransmissible is I suppose a different thing. Is the step before really internalizing that undetectable is untransmissible, and it's kind of hammered home for me in a conversation that I had with colleague recently about a newly diagnosed patient. But the first thing that happened was a note on their notes: extra care with taking bloods, and I started sort of challenging my thoughts around that. Why extra care? In a situation like this, what actually should we not be taking extra care with all bloods, with all potential, I suppose, needle stick or transmissions, and what potential consequence might even thinking to record that on a patient's notes have on them, their care, the bigger team?
Yep. No, exactly. And it's not even logical if you think about it from a scientific point of view, because if someone is known to have HIV and they're on treatment, actually, there is no extra care that is needed. You you need to take extra care with someone who doesn't know their status. So it's not even logical. Um, and if that patient were to see that on the notes, or if someone else from the team sees that on the notes, it can be very detrimental to maybe how they, even in your subconscious, on how you treat somebody, and that can lead to you saying something that is stigmatizing, and we can talk about language that we use later on, but that can result in a breakdown of trust with that patient, and them internalizing that stigma themselves, and they feel that they're to blame, or that they don't deserve care, and that can lead to them not accessing their GP surgery. And it's all stemming from that incorrect statement that is not even scientifically correct. Do you know what I mean?
And it's about leadership as well, because actually, people who do that, people will follow them and do the same thing, and it perpetuates the issue. Whereas actually, when people see, completely taken all this away, treating this person completely normally, this is the way that we tackle HIV stigma, by normalizing everything. I think it's so important. So really seeing that leadership and not doing practice like that Grace just talked about.
Mm. And I think you're right. I think a lot of this comes from leadership, and I think it comes from a whole team approach.
Yeah.
We talked before about sort of overheard conversations about double gloving or extra precautions in certain aspects, and it's from a variety of different teams. I think having the confidence to stand up and confidently say, well, actually that's not the case, or actually this is potentially damaging, stigmatizing behavior or thought processes.
Yeah, it's having those conversations, but they have to be open and honest conversations, and yeah, you have to be able to challenge, but also understand that where that stigma comes from. If they haven't had that education, you have to be supportive and actually provide that extra guidance. Because if someone doesn't know the science behind it or the new advances, how we expected them to change their attitudes. So that is something that we are working towards as HIV champions, is to provide more education to all primary care teams.
I suppose one of the things that I think would be helpful to explore here is that education is really at the core of a lot of this. What's the consequences of not doing this well? What is the potential impact on the patient and sort of community of, for instance, not challenging that extra caution when taking blood tests?
I think for me, what's really important is the impact on people living with HIV. One of the biggest issues we're seeing now is not people with undiagnosed HIV, but actually people disengaging with their HIV treatment and care.
Mm.
And the worst impact of this is that if somebody has a negative experience in healthcare, it could lead to somebody choosing to disengage, which could mean that they are both poorly because they're not taking the medication, and could potentially pass it on if they did become detectable. Nobody wants that. People living with HIV don't want that. The health system doesn't want it. So we've got to make sure that we're doing all we can to prevent that. But that is the kind of really hard edge of it all. Other things are just about confidence, well-being, the people feeling safe and secure, and that psychological safety and all those kind of things. So it's kind of, how do we make sure that we're achieving the best outcomes, really, for people living with HIV? And so that's why it's important to challenge it. Grace?
And, and this is something that we do in general practice all the time with our patients with long-term conditions when we do their long-term reviews. So, for example, with diabetes, type 2 diabetes, when you have that conversation, you see their HbA1c has gone up to 85. They've put on weight. They might not be taking their medications as prescribed. We all know that, wagging your finger and saying, tut, tut, you didn't do this, you didn't do that, that's not going to help anyone. And we know that our patients will just not rock up at their next appointment because they don't want to get told off. And that's exactly the same with our patients living with HIV. HIV is a chronic condition. If they are struggling with something, or they might have difficulty with their medications or not going to their clinics, um, they don't want to be blamed for their condition or blamed for why they're being poorly, or stigmatized, because that's not going to be helpful in building that relationship, that trust. And also, if people feel stigmatized, sorry, it's very isolating, and
Mm.
that can affect their mental health, and that sort of puts them in a cycle that they can't get out of, and therefore they don't take their medications, they become more unwell, they become more isolated. They then don't want to come and see you because they're worried that they're they're going to get either told off, or someone in reception might not have the same sensitivity when talking about their HIV. And so, yeah, so So if you keep in mind that HIV is a long-term condition like diabetes or hypertension, and think how you would manage patients with those conditions, that's how we want you to feel sort of confident and empowered to talk to people living with HIV.
This is quite a challenging thing, I suppose, to hear as a GP that's not an HIV champion, but learning lots and lots about it now. Actually, sort of seeing this as a chronic condition, which of course it is, and in a similar vein to diabetes or cardiovascular problems, I think it's very, very useful. But it's quite hard to make that mental shift, I think, and I think that's where work needs to be done. Would you agree with that?
Yes,
Mm,
absolutely. That is definitely something that we are working towards by promoting universal HIV testing,
mm.
especially in A&E departments, and also at NHS health checks and at new patient registrations, trying to normalize HIV. And also with our patients, we put posters up in reception, or we raise awareness in HIV testing week. So we're really trying to make it more normal, less stigmatized, less embarrassing, um, and yeah, we hope that this will help to reduce stigma um, and make people feel more confident in primary care.
I think that's at the crux of it, and I think this whole team approach is so important. Is there any ways that people can update themselves on that? You mentioned confidence, and I understand there's some confidence charter.
Yeah, so I think one of the ways that people can increase the confidence and understanding around HIV is the HIV Confident Charter. And ultimately, it's an education tool, an awareness tool, but something organisations like GP practices can sign up to get all the team on board to make sure that they're aware of HIV, have inclusive policies and procedures, and do really positive affirmative stuff around HIV. And you'll get assessed, and kind of you get to do a lovely little logo thing as far as that self-assessment goes, really. But it's ultimately just about skilling people up on HIV. So it's really, really helpful. It's really useful. It's simple. And it's something that all the team can get involved, as Grace has said.
And it's also free, may I add.
Important point
Even
there.
better, yeah.
Absolutely. And I have been told that it does look very good for CQC inspection as well.
Yeah, it sounds like a win in all respects. It's nice to have some practical things to do because I think that when we encounter this, and especially if we don't encounter particular problems very frequently, and of course different areas of the country will have this um, more or less frequently than others. Um, it's having those skills, and a big part of the skills is having conversations and using good language. I shy away from using the word correct language, but better language, inclusive language. So I was wondering if we might be able to explore that a little bit. How are we doing at the moment?
So I think from our perspective, we as an organisation at George House Trust, we're getting a lot of feedback from people about kind of hearing what they would call stigmatising language. So instead of saying someone's living with HIV, it might be they're infected with HIV.
Mhm.
So small changes around stuff like that. Actually, when we're talking about people living with HIV, we use that terminology because it does have such a much more positive impact. But even really simple things that you're like, oh, when disclose their HIV status. Well, disclose is hidden in secrecy and things like that. Actually, what we want to do is sharing their HIV status, being open about that, and kind of using much more positive language. I think there's kind of all the stuff around compliance and adherence and court and all those kind of things. We kind of just want people to use the right language. But what's really important is it's not about catching people out. It's okay to get it wrong and learn. And I think that's fine because we're all learning and language changes and evolves. And it's really important that we kind of don't hold people, kind of feet to the fire on this. It's like, how do we improve that and skill people up and educate in this space? And so we've got a language guide on George House Trust website that people can go to, and it kind of helps people to understand that. It's a really useful tool. It's something that can be shared around in a team meeting, for example, things like that. But it's just to help guide and educate to better support people living with HIV.
That sounds extremely helpful, and I think having a language guide that could be shared in a morning meeting, and it could be some reading for people to do. And I think that actually it's quite useful for HIV, but all chronic conditions. I think there's a big move, quite rightly so, away from sort of defining people by their illness, and rather as a person that happens to have some medical problems that we're there to help with. And I suppose it feels very dehumanizing when people talk about, about being infected with, as you say, disclosing. So I think that's really nice to sort of change that narrative.
Yeah, I completely agree. And like you said, the really easy thing is just using person-centered language and putting the person at the center of the conversation. You'll do it naturally, and you'll
Mm.
pick up the right words on the basis of doing that.
So the language used in consultation is really important, and I love this idea of a person-centered approach, putting the person at the centre of the consultation, and particularly when we know that there are more delicate or stigmatized conversations to be had. I think quite a lot of it comes back down to engagement with the patient and building that trust, which of course can be eroded bit by bit and insidiously and non-intentionally. And it's I think it's a good message to say not to be too hard on ourselves and to challenge ourselves and learn rather than say you did that wrong. Um, and actually building that trust and making sure that we're improving to help keep patients engaged with their treatment and engaged with primary care, because that way when adversity happens down the line and people may be disengaged from their treatment, we can help bring them back in again, as we discussed in our second podcast.
Yes, absolutely. Because if patients feel that they've got that good connection with us, there's that trust, then they're going to be able to feel comfortable coming to tell us if they're in difficulty with the medication, or they've unfortunately not engaged with their clinic,
Mm.
and we can support them to go back onto treatment, so we can prevent them from becoming poorly, unwell, deteriorate, and even worse outcomes, like early mortality, that we know that that happens in sometimes in patients. And we really want to, yeah, build that trusting relationship with our patients living with HIV, because I think that's one of the main points that we can work on to try and end new transmissions of HIV.
So I think that's a really good way of looking at things, in the way that it is a chronic condition. This is a condition that people are going to be living with for a long period of time, and and I think starting treating it as we might diabetes or hypertension or cardiovascular disease and any long-term condition, I think it's a really good way of looking at it. But I think it's probably quite challenging for teams, and speaking as sort of as a non-HIV champion or specialist, actually really moving our mindset from a thing in its own right to actually this is a long-term condition. I think it's a real challenge for teams. What would your thoughts be around that, Grace?
I mean, I can totally understand, because whilst I am a GP champion, I don't prescribe medications for people living with HIV, like antiretrovirals. I don't see patients in clinic, and we're not expecting GPs to suddenly to be able to do that and prescribe medication and make those kind of decisions. But we are going to have to learn how to be comfortable and confident just dealing with HIV in general, know how it's uh, passed on, how it is managed in secondary care, that you need an undetectable viral load to be untransmissible, and sort of know how to support patients. Because whilst I am an HIV GP champion, I am not a specialist in any way. I am a GP first and foremost, and I as my job is making sure that I know how to manage people with long term conditions. I know when I need to refer them on to see the specialist, but I know also what I can manage in primary care. And so we have to learn to challenge the stigma that we have, our internal stigma, our prejudices, because that is how we're going to be supporting our patients.
Yeah, long term and manageable. And I think that's the take home message, isn't it? Like that this is a condition that people are going to have for a long period of time, but they're also going to have other medical problems that we're going to need to be dealing with alongside. So maintaining that trust, maintaining that interaction, knowing that people can really trust in their GP, because that's at the core of everything that we do, isn't it?
Absolutely. And people living with HIV will go, as Grace said, to the clinic, that get their HIV medication and have that side of the care. But the GP's got to look after everything else. So you've got to have that awareness, be able to have that conversation, help people to feel safe so they can have a positive conversation. Because yes, they have got a manageable long-term condition, but they've got a bad back, mental health, and all the other things that you might need to see a GP for.
Oh, exactly right. I mean, and hopefully we're starting to make some headway into this. I think that you shared with me a study that now 95% of patients want their treatment disclosed to their GP. Um, is that correct? And has that always been the case?
So we've seen it gradually change over the years. So yeah, we did a survey a couple of years ago, and 96% of respondents had told us that they actually had informed the GP about their HIV status, which is really good because the GP having that information can look holistically at that individual and see what might be needed and be aware of prescribing and things like that. All those kind of things are in there. But historically, there have been factors that have prevented people being open about the status and what goes on medical records, access to insurance, kind of mortgages, all those kind of things. Now, discrimination in that space now, kind of has moved on significantly as far as it's reduced. And so that's really good. But people still have that anxiety. Where's that information going? Who's going to see that? And so we've still got a bit of work to do to help people to understand that confidentiality within primary care is just the same as it is everywhere else. So everyone's, kind of got responsibility to do that. But actually, it will lead to better treatment outcomes if people are fully aware of exactly what's going on around your health.
I think that's really good to hear that there is improvements being made. It sounds like there's a lot of work to be done, and lots of great work that George House Trust has been doing as well. But I think that we as GPs are, are community advocates, and we've got HIV champions such as Grace. But I was wondering, asking the both of you, how can we challenge stigma in primary care? How can we challenge stigma in healthcare? And what would you say is the most important thing for us to do?
I think, well, firstly, you should challenge your own beliefs and your own thought processes before going anywhere else. You know, we've talked a lot about different, scenarios and things, and maybe think, what would I say to a patient who told me that they were living with HIV? What would be my initial reaction? And that's a good place to start, is think about what you would do yourself. Um, and then I would say take yourself to the George House Trust website and have a look at the language guide, because I found that very, very useful. Many words that I have been using that I didn't think could be stigmatizing. So I've definitely changed my practice. So thank you very much, Darren, for that.
And I'd recommend everybody comes to George House Trust website as well. But I think the really important thing is, and not to quote a previous prime minister, it's education, education, education. And so by having information around, we talked about information resources, posters, facts. We've mentioned undetectable equals untransmittable, or U equals U, or on a really simple level, can't pass it on. We use a really, really kind of just a small little business card with 5 facts about HIV on at George House Trust. We just want people to know the basics because that'll help and it'll increase confidence to have conversations about HIV. And that's what we're talking about when we're tackling stigma. It's about giving people the confidence to be able to talk about it and not be scared. And so, it really is about educating each other.
And something that James, I think you, or maybe it was Darren, sorry, that you said earlier, that we're not here uh, to blame anyone for the language that they're using. I think challenging it and raising awareness, but not in a blame or shameful way. We're all here to learn and we all want to be better. We're all working in healthcare. We all want to help people. So yeah, but so I think, yeah, challenging yourself and others, but it is our responsibility to do so. It's nobody else's. And we've got lots of resources to support you with this. Like Darren said, we've got the George House Trust, there's the Terence Higgins Trust website, and there's of course the HIV Confident Charter, that is a free tool that can be used. You just sign up, and we'll put the website on the show notes. And it's it's a really actually easy e-learning module that I think it takes maybe 20 minutes. Some really helpful lessons to be learned from that, and very accessible. And yes, but by creating a very non-judgmental, respectful environment, that is how we can really empower our patients to take control of their health, no matter what condition they have, whether they're living with HIV or any other chronic condition. So yes, that's the message that we're trying to put across.
And that is an absolutely wonderful thought to end on. We've been on such a journey today, in fact, throughout the entirety of this series on HIV, and I think that going on this journey from I suppose the medical end of things and diagnosis, treatment, looking at those medical aspects of things that we can do, now onto this just really, I suppose, broad but so important consideration of HIV as within our populations, within the human beings behind it, and challenging ourselves. So I've really challenged my thinking. I'm so glad that we've been able to have these conversations.
Well, thank you so much again for having us and for doing this series. For those of you who haven't listened to the other episodes, they are linked. So yeah, please do um, share this with people in your team, and look at the resources that we've provided, and do reach out through GP Notebook if you wish. Thank you.
And thanks for having me on today. It's been really interesting talking to you. Obviously, we put people living with HIV at the heart of everything. We want everyone else to do that, but if they're not able to, they can get in touch with us and we can help them.
Excellent. Well, thank you so much, Darren. Thank you so much, Grace. And thank you to my other guests throughout this series. And thank you, everybody, for listening at home. I hope you have found this interesting and insightful, and you've been able to challenge some of your thinking and some of your practice throughout this series. I look forward to many more conversations about this within my team, and hopefully you'll join us at the next podcast. Take care, and we'll see you next time. Bye. So thanks again to Dr. Grace Bottoni and Darren Knight for sharing their insights. And thank you to Grace for helping me organise this series and bring such wonderful guests. We've heard today how stigma isn't always loud. Sometimes it's in the notes we write, the tone we use, or the systems we don't question. But we've also seen that it can be challenged through education, reflection, and open conversations, of which you've been part of it today. By listening, you're already doing the work. Keep learning, keep reflecting, and keep asking how we can make general practice safer, kinder, and more inclusive for everyone. So thank you for being part of this series and for everything you do, and we'll see you next time.